With that, I go with the topic of my talk. My perspective on innovation, education, patient care, family value, and philanthropy. These are my conflicts, and two of them do directly involve. And these are Stryker and Depew. I start with a quotation from Santayana, "Success and failure. Those who can't remember the past are condemned to repeat it." I have been involved in the Knee Society and its formation for the last 50 years, along with J&J, and I'm going to describe part of that relationship and that success story. In anything you do, surround yourself with good people. It is the combination of the intellect of the people along with you makes anything go. Have internal commitment, and I believe no commitment is complete unless you can write it down. Thinking alone is not enough. So that's one of my message to you today. The historical perspective, how the knee replacement evolved, is as follows. In 1971, we designed, and this was the first condylar knee implanted in the Western world. I am the operating surgeon. John Insel is helping me, and Peter Walker is standing with the hand across the chest. We also designed a Knee Society score, which is called then Special Surgery Score, which later on modified to become a Knee Society score. All scores are good and meaningful, however, they are laborious to fill, and the scores are only good if they are filled properly and completely. So, to make it user-friendly, I designed another patient-administered questionnaire, PAQ, which take into account only 5 items: pain, noise in the knee, activity level, effect on well-being and satisfaction. Lesson learned from the first knee, which I did about close to 200, were instability, failure of fixation, patellofemoral pain, and technical difficulty of aligning and balancing. You require a lot of ability. So the data of cruciate saving knee were, in our experience, where duocondylar was not good. So we went on, along with Dr. Insel, to design total condylar, and you could see I did the most of the investigative work, and these are, I think, 9 or 11 papers published on total condylar. We designed constrained knees also at the same time, and they are shown here. We are still using the TC3 rotating platform and constrained condylar, which began then. CR and PS knee. We believed in PS knees. Boston surgeons believed in CR knee, that is cruciate retaining knee, and we had an ongoing discussion and difference of opinion on this matter. Suffice to say when you save the cruciate ligament, it is difficult to balance a deformed knee. It's easy to do when there is no deformity. And most of those knees, in my opinion, even may not need surgery. History of total knee in India. In 1968, I got to know Dr. Dholakia. I spent 9 months with him, and at that time, these were the surgeons in different parts of India. They were using these knees in different proportionality. Geometric knee was the first knee introduced. Here, the first knee done geometric in Bombay Hospital. This is the first total condyle done in Bombay Hospital in 1977. This is the first bilateral knee done at Bombay Hospital. So me and Dr. Dholakia became friends. He visited me several times in New York, and this is one of his visits there. So success and failure in anything, and here I'm referring to knee replacement, history provides you the opportunity to study, analyze, define, and document the reason for failure. If you cannot understand the failure, you cannot make an improvement, and if you do that, success becomes the dominant theme. In 1983, I invited these 20 surgeons and formed a knee society of America, and this is the picture from that time, and I served as a founding president for 2 terms. I learned a lot of lessons in life, but this is one of the more important ones. The money, the biggest divider of friends, family, and institution. And this, I'm talking in reference to royalty income, which we brought to the hospital, and hospital will or wanted to keep all for themselves. And that's where the debate began. So the line I wrote then, money the biggest divider, friends, family, and institution. We designed several knees, and here is one of them, which is PFC CR and PFC PS, a modular knee. And this is the first PS knee done in 1989, and this patient is still alive, and this X-ray is 24 years post-surgery. He plays once or twice a week tennis, and he did that for many years, not at the present time. We described the technique of doing the total condylar knee, and the principle involved was you have to align the bony elements, you have to balance the soft tissue, you have to provide gliding of the patella, and you have to have a good range of motion. All these principles were devised then. We designed further improvement and modification of Sigma PFC knee, and they are listed here. One of the problems we noted that as rotational freedom was limited, there was damage to the post, both due to rotational restriction and as it was a PS design behind the post. And we made improvement on those, and we also improved the base plate from titanium to polished chromium cobalt. The principle of rotating platform introduced by me in 2000, and some of you may not know, I am the patent holder of that design. I got the concept. I say, why do we need rotational restriction? So create a rotational freedom by creating a rotating platform knee. You all know very well that all published data and all talks do not have a appropriate value unless they are level 1, 2, or 3 evidence. Thus the highest level of science. However, most of our communication and teaching occurs at level 4 and level 5. So keep that in mind. Indication of the total knee have become more liberal. We are doing more and more in younger people and more less deformed knees. Fixation-wise, I still believe cement is the gold standard. Non-cemented fixation is coming and may someday take it over. The total knees done in US, according to one data, is about 800 per year, and that was in 2012. It is over 1 million now. Various kinds of incisions have come and gone, large, small, and medium. My opinion has been, use that long incision so that you can perform and cement, if you are using properly, and produce a good outcome. Cement fixation, as I said, is the gold standard, and this is the first paper we wrote and followed on total condylar for 20 years, and this is published data. Not only we had the good results, these are the top 15 papers, a 15 to 20 year follow-up with 80 to almost 99% success rate. Level 1 evidence, these are the 2 papers here in the knee by Parks and Baker. I have surveyed the literature quite well, both on cement and cementless, and this is the data I'm showing on cementless. Cementless data is 10 percentage point inferior in survivorship compared to the cement. And these are the registry data on the statement I just made. Meta-analysis is a powerful way of analyzing information, and Gandhi paper in 2009 is a good example, telling us that cement fixation, at least up to that time, was ahead of non-cemented fixation. In my opinion, non-cemented fixation, as I said earlier, is around the corner, is growing and will grow further. Higher range of motion we all want, but it's not a free lunch. More motion you give, you create a slight risk of instability and subluxation. So be prepared for that. What we have learned in the current innovation, that if you can recognize a problem, then it's easy to solve it. So always look for why something is not working at home, in your car, in your house, in your operation, any place. Find out the cause and then try to fix it. If you can't recognize the cause, root cause, you cannot fix it. These are the early and late causes of failure for completeness. And here are the incidence of these causes is put together by Sala. And other people have looked into and has given us reason for failure. Number one cause for knee failure is loosening, second, instability, third, wear, and this is in the main joint, and patellofemoral joint in itself stand by its own merit and have some failures. In 2005, I called for a meeting and these people came, and that led to a design of a new knee system which is called Attune. And the improvement were more size option, better trochlear groove, more range of motion, superior quality polyethylene, and instrumentation to implant correctly and properly. So where are we going in future? We are attempting to improve polyethylene wear. We are attempting to improve fixation with non-cemented methods. To do that, we have different materials and different inductive agents in which we are trying and making it better. Range of motion, in my opinion, up to 135 is doable, but 135 to 145 to 50 is where the problem begins. You have a lift off, you have a wear, and this is, in my opinion, just not possible. Customized instrumentation are around the corner. We have robotic surgery. We have other methods to align the knee properly. However, all these add to the cost. And those surgeons who do 50 to 100 knees a year may not need any one of these adjoint technology. So what I have learned, attention to details to identify a problem. Study, analyze, and define the issue. Set a clear goal with passion. Find a solution in timely manner. Appropriate allocation of resources. Proper research, education, and marketing. Giving back, share your knowledge, educate people, and if you have enough money from the profession or otherwise, share it. And always be prepared. And with this quote from Greece, nothing endures but change. If something is not working, try to improve, and that's the way the life goes. For adults, at your home, with your children, the best way to educate the grown-up is by example. Giving back, what I have done is taught residents and fellows over the years, and these are the number. 170 residents at special surgery and Lenox Hill, and 143 fellows, 75 at special surgery, 28 at Lenox, and when I come back since 2008, 40 additional. RORF, we have a fellowship sponsored from RORF. We take one every year, and we have taken 60, and we finance their travel and stay at New York. And these are some of them. Success in life. Goal, passion, plan of action, resource allocation, periodic assessment. Family, I'm proud to say that there is no other university where father and two sons in the same specialty, professor, and associate. I'm very proud of that. Philanthropy, over the years, I have given 7 million to each of these entities listed here. For leadership, I believe, and I have done it, surround yourself with good people, identify the problem, I'm good at that, study, analyze, synthesize, and articulate in a manner so we can all understand. As a surgeon, your goal is patient care of high quality. Don't ignore the family, research, education, and if you have it, share it. I thank you for your time.